Are we ready to get started? Yes. Okay. Well, thank you for joining. I know a couple of other people will be trickling in as we start, but my name is Allison, and welcome to our webinar. I will be moderating today. I'm the founder of Better Aging and Policy Consulting, and one of my recent projects has been with MIT CoLab, a nonprofit affiliated with MIT focused on economic justice. And the recent topic they focused on was LTSS, long-term services and supports financing. And we have two of the fellows from that program here with us, Ben and Adria. Uh, but this report that Ben wrote came out of some of the work that was done with MIT CoLab. We're very excited to hear all of his learnings and how they apply to the US. I will briefly introduce our panelists. I'll give you a run of show, and then I'm going to just kick it off because we have a lot to discuss today. But throughout, feel free to put any questions in the chat. Questions or comments in the chat, and then we also have the Q&A activated. We're all here to learn more about Ben's new report, Promising Housing and Long-Term Care Innovations for Person-Centered Aging Amid Financing and Workforce Challenges, Lessons in the Netherlands. It's a little, a little bit of a mouthful, but you will see a direct link to the report in the chat momentarily. Kristen, if you don't mind adding it. And Ben is the director of the Washington Care Fund, which is Washington State's first in the nation universal public long-term care insurance program. It's very exciting. We're all keeping a close eye on it. And um, he is also a board member of the American Society on Aging and the former research director at Caring Across Generations, as well as the former VP for Policy at the National Academy of Social Insurance. So we are excited to hear from his expertise and learn all about it. After he shares more about the report and the learnings, we are going to hear from three panelists. First is Adria Powell. She's the president and CEO of Cooperative Home Care Associates, which is one of the largest worker-owned co-ops in the US. It is a training, home care, and workforce development provider in the Bronx, and its workers are organized by 1199 SEIU. She's also the secretary of the board of directors at PHI. We'll be joined by Robert Jenkins, the managing member of Jenkins Consulting and former director of social impact initiatives at the National Cooperative Bank, managing director for aging and independence at Capital Impact Partners, and director of the Robert Wood Johnson Foundation's Greenhouse Project and Coming Home program. And last but not least, Peter Alders, who's the program manager of Aging in Place at the Dutch Ministry of Health, Welfare and Sport. Also the former policy advisor for the Ministry of Social Affairs and Employment and the Ministry of Finance, and a researcher at the Erasmus School of Health Policy and Management. So thank you all for joining us. Ben will kick it off by providing an overview and some lessons from this report. Then we'll ask a few questions to our panelists, and we'll open it up to Q&A. So again, please post any comments or questions in the chat and in the Q&A. And with that, I will turn it over to Ben. You are muted.
Thank you so much, Allison, and thank you for all of you for joining us today. Excited to talk to you. That we have a fantastic panel here to help shed light on what we can learn from the Netherlands and how we can make our more access to person-centered care more broadly available in the United States. Next slide, please. So countries around the world are facing the same challenge today, which is we have aging populations throughout the OECD. Programs, like the Dutch program and some other European programs that are and Asian programs that have universal coverage, face the challenge that with projected fiscal and workforce constraints, which are faced by all of these countries, the shortage of long-term care workers, the fiscal demands of an aging society. Given these constraints, the more generous programs, such as the Dutch program, are looking at how they can continue to provide care to everyone that's quality care, person-centered, but in a more efficient way. And in the United States, we face a different problem, obviously, where we don't have universal coverage, except in Washington State, we do now with the Walk Cares Fund, but it's a modest benefit. But for the most part, we don't have universal coverage. But to get to a point where we do have universal coverage, we would need to be able to find more efficient ways of providing long-term care in order to be able to do so in a fiscally sustainable way. And we also have to figure out ways to do it, just as the European countries and Asian countries do, in ways that require less workforce and less formal care overall. And so the redesign of the way we provide long-term care is critical to being able to achieve universal coverage and to the ability to make person-centered care and person-centered aging broadly available. Next slide, please. You're all familiar with the statistics around an aging society. In my state alone, the population 85 and older is quadrupling between 2025 and 2050, while the working age population is stagnating. The ratio of people of prime caregiving age, 45 to 64, and this is the group from which we draw a lot of care workers, but also primarily family caregivers. Really, both groups are drawn heavily from this part of our demographic spectrum. The ratio of people of prime caregiving age to people 80 or older who are likely to need care is declining from 7 to 1 in 2010 to 3 to 1 in 2050. So with the growing scarcity of loved ones to care for older adults, for people like us as we get older, social isolation, which is already suffered by 1 in 4 elderly today, will become even more prevalent in the coming years. Next slide, please. So the challenge is to render person-centered care broadly affordable and accessible. The strategic framework for a national plan on aging, developed by 16 federal agencies led by the Administration for Community Living, considers person-centeredness as a foundational value and defines it as follows. The preferences, needs, and voices of older adults drive the services and supports that enable them to live the lives they want. The Alzheimer's Association provides a definition specific to aging-related long-term care. Person-centered care is a focus on elders' emotional needs and care preferences consistent with their lifestyle. The emphasis is on relationships in the care, what's called the social model, rather than task-centered approaches that focus on the physical health of elders alone, which is referred to as the medical model. So at its core, it is being in a setting, person-centered care and person-centered aging is about being in a setting that either is your home, or feels like home, not in an institutional setting where you're treated like a patient and decisions are made for you on your behalf. And it requires the person having some appropriate level of autonomy and control over their environment, co-determining their social life, medical care, and social support as needed. But it's more than that. It's also simplicity in accessing housing and care. In the United States, we have a complex web of benefits for housing and care that are all, except for the Walk Cares Fund in Washington State, they are all have income eligibility and often asset eligibility criteria. And so individuals who want to access these benefits, which are only available to the poorest among us, have to navigate a complex web of criteria. So that is not person-centered. Person-centeredness also means being in a safe neighborhood with access to amenities and social engagement, being able to meet one's needs as a whole human with social interaction. Person-centeredness is hard to scale for reasons that Robert, Adria, and Peter will address during the panel, not least because it has an organic element that requires architectural and social intentionality, and also requires stakeholders and residents buying into that architectural and social design. Because of that, I'm so pleased to have Robert here with us today because he has a tremendous expertise in these areas. The philosophical question arises, should person-centeredness be viewed as a luxury affordable only by the most affluent, or the way we all age? If you believe this is the way we should all be able to age, then I think you'll find a lot of interesting insights from today's panel. Making person-centered care broadly available would also require universal coverage for long-term care and much broader access to affordable housing for older adults. Next slide. So why is the Dutch case so instructive? Facing similar demographic challenges with similar fiscal and workforce shortfalls, the Dutch have developed promising innovations that strengthen person-centered aging while simultaneously bending the cost curve. They were able to do this because the social model of care is actually much less expensive than the medical model of care. Aging in the community, aging in a person-centered way is often less expensive than medicalizing the final years of our lives, especially through nursing home care. So the Dutch case shows us how to kill two birds with one stone, that both of these goals can be achieved at once. Next slide. So today I'm going to talk to you about I'm going to provide an overview of the restructured Dutch long-term care system. It's talk about caring communities, innovations that have proliferated in the Netherlands, talk about provider innovations, and finally draw some lessons from the Dutch case for the United States. Next slide. And next slide. So in 2015, the Dutch government undertook a radical reform of its long-term care system. Again, it was in a position where it was an extremely generous system, but it was heavily weighted on institutional care, paying a lot of housing costs for older adults, often to be in a nursing home when they didn't necessarily need to be from a care perspective, and where it actually wasn't even person-centered to have them in that environment. And the program was going to become unsustainable both fiscally and in terms of workforce demands. So in 2015, the government undertook a radical reform with three goals. The goals are actually two goals of fiscal sustainability and person-centeredness. It divided its previous program, which was one conglomerate that provided all long-term care, healthcare, institutional care, social support, into three separate programs. Institutional long-term care and highly intensive home care are now financed and administered through the Long-Term Care Act, LTCA. Nursing and personal care at home are now provided through the existing social health insurance system governed by the Health Insurance Act. So that integrates medical care, medical insurance with home health care. So it provides holistic health care for people who need long-term care. And other long-term services and supports for people living in the community, such as home modifications, cooking, cleaning, transportation, and assistance with social participation are now provided through the nationally funded, municipally administered social assistance system governed by the Social Support Act. I also am releasing a tandem paper in January with the National Academy of Social Insurance, which will go into more depth on the public policy dimensions of all of these reforms. The system as a whole covers both home and facility-based long-term care for all its residents. For home health care, there are no copayments. Ancillary care, the social support care has a nominal copayment of 20 euros a month, about $22 a month. For institutional care, there are income and wealth related copayments, but the copayments are far lower than in the US. They range between $200 and 200 euros and 1,000 euros a month for the first 4 months, after which they increase to a maximum of 2,887 euros per month. So much lower than the costs, the out-of-pocket costs we face in the United States. Next slide, please. So today I'm going to talk about different components that are necessary to, that have been successful in the Netherlands and I think we're worthy of looking into in the United States. Affordable senior housing, caring communities, provider innovation, and then multi-sectoral collaboration and planning. Next slide. So there are a variety of caring community initiatives that have proliferated in the Netherlands over the last 20 years or so. Most of them are grassroots or have origins in the grassroots, but are also supported by government incentives. Next slide, please. The first one is a purely grassroots phenomenon, the resident care cooperatives. These are initiatives where, which are similar to the village movement in the US, where neighbors help neighbors. In a neighborhood or village care cooperative, residents form an association that individuals, and in some cases stakeholders as well, can join by paying a low annual membership fee. Members commit to offering neighborly assistance to those needing support by going shopping, doing odd jobs around the house, providing transportation, supporting social engagement, or offering companionship. This has been a successful way to help fill in the gaps as the Dutch long-term care system as a whole is trying to shift away from providing as much formal and institutional care as it had been providing towards being more efficient. These resident care cooperatives fill in a lot of the gaps, particularly in rural areas, and have been really effective. 16% of Dutch adults 50 or older are engaged in informal caregiving, versus 7% in the United States. Next slide. The most promising housing and long-term care innovation, and really where the most energy is in the Dutch reform movement, and Peter will talk about this in a moment, are reciprocal care communities. Dutch reciprocal care senior housing can be understood as US-style independent living, but with architectural and social innovations designed to foster community engagement and mutual support. It builds on the model of co-housing with roots in Denmark since the late 1960s, which combats social isolation by creating shared spaces for community engagement. Cluster senior housing is also typically strategically located near public transportation and desired amenities, making social participation much more feasible. Nursing care is available if needed, but many social care needs are met by neighbors looking after one another. One interview partner noted, I think you want housing where people who are more or less fit and people who are more or less not fit live together, where there is a big kitchen and where you can cook and eat together. Because if you're used to cooking and eating 1, 2, 3 times a week together, and you get sick and you can't come out of your apartment, then your neighbors know you well and they'll check in on you and make sure you're okay. And if necessary, alert the nursing provider. Based on my expert and resident interviews, early indications are that the reciprocal care model holds considerable promise. Most residents move into a clustered housing community where they're still relatively healthy and gain a social anchor in their new community before they need significant nursing care. It makes it possible for neighbors to look after one another and also promotes more active, healthier aging compared to being alone at home in front of the TV, which is the fate that many had experienced before they moved into these communities. I conducted site visits of 2 of these communities, live in Hilversum and Knarhof Gouda, and I'll talk about these in turn. So Live in Hilversum is a 170-unit senior housing community near Utrecht, completed in 2021. In 2023, rents averaged 622 euros a month, including utilities, which makes them affordable. With housing they even have housing subsidies as needed for people who can't afford that. The tandem publication I mentioned will go into much more detail on why the housing is so affordable. It has to do with the tradition of social housing in the Netherlands. Live in Hilversum is the result of a decade of planning and experimentation by Habian. It's the housing association that built it, in response to the government shift away from funding facilities that offer nursing home care and housing, nursing care and housing conjointly, the nursing home model and the assisted living model. Each time it began planning a new community, Habian asked prospective residents the same 3 questions. How do you want to grow old? What do you need to age the way you would like? And what can you bring to or do for the community? And the residents that, based on the responses to those questions, residents are selected, and they've managed to find a really good mix of healthier and less healthy residents. Sometimes there's couples where one has dementia, the other doesn't. And because of the mix of residents, the person without dementia is able to live a fulfilling life in that community while still being with their partner. It's a very successful model. Another model is Knauenhof Gouda. I won't try to, in the Dutch it's pronounced Gouda, but I know Peter's with us, so I didn't want to fully mispronounce that. Another age-friendly clustered housing model. It's founded by the foundation Knauenhof, which supports small groups of older adults who express an interest in establishing a socially engaged senior housing community. The foundation facilitates largely grassroots, resident-led initiatives to envision, co-finance, and build retirement communities. Two things are particularly innovative about this model. First, the prospective residents co-manage the entire development process from concept to delivery, together with the foundation, which serves as a project developer and manager. It thus resembles a franchise model where the franchisee is a group of engaged residents. This helps with scaling, obviously. Second, beyond the existence of some social housing units within each community, the overall concept has a co-op dimension in that the Knauenhof sells the land to the residents at cost, not at the market price, and in turn stipulates that when one of the owners sells their Knauenhof home in the future, the profit returns to the foundation so that future buyers can also access affordable housing. The first Knauenhof development started its planning process in 2011 and was completed in 2018. By the spring of 2024, a total of 8 Knauenhof communities had been completed, and 43 other initiatives are in various stages of development. Throughout the Netherlands, more than 31,500 older adults are either engaged in Knauenhof resident initiatives or have indicated their interest to become engaged if suitable land were to become available for Knauenhof development in their community. In key ways, the Knauenhof concept is similar to that of live-in. Both models seek to facilitate aging in place and forestall the need to move into a nursing home. There are also differences between the two. The paper goes into both in much more detail, but again, this is a model where because residents can look after one another and really leverage the social capital of the community and build a new community, instead of waiting until people are old and frail and have severe dementia to move into an environment like this, they move in earlier when they're healthier, kind of like the independent living model in the United States, but with architectural and social intentionality to foster the sense of community that brings that social engagement. Because that social engagement occurs and that reciprocal care occurs, they've already finding that they're saving money on healthcare costs, and the hope is that less formal care overall will be needed for these individuals because they'll be healthy, have healthier, more vital aging, and also have a component of reciprocal care, including things like standing vigil when hospice is provided in these communities. Next slide, please. Another caring community model getting traction in recent years in the Netherlands is intergenerational cohabitation. Facility managers committed to more person-centered care began to seek new strategies for not only keeping residents alive, but also combating social isolation and providing residents with an environment more conducive to joy, vitality, and healthy aging. This strategy also helps mitigate a shortage of affordable student housing in the Netherlands. Just as the previous model of reciprocal care communities also frees up housing for younger families because older adults move into these communities earlier in their older years. As such, offering students free or subsidized housing in senior housing communities addresses two problems at once. I won't go into detail on this model. It's exists in the United States as well, but it's a promising model for more holistic aging in a more organic way that feels more like normal life. Next slide. Next slide. Next slide. So I'm going to talk for a moment about a couple of provider innovations. The first is buurtzorg. In 2006, a visionary Dutch community nurse, Joost de Blok, pioneered a new approach to the provision of home health care. Together with his colleagues, he founded the nonprofit nursing agency buurtzorg, a Dutch term which translates as neighborhood or community or district nursing. At the time, the prevailing mode of home care delivery was that a home care organization would send a nurse to provide home health care and send home care aides to perform personal care. Notably, it would not be the same nurse or the same home care aide each time. In some cases, clients would see up to 36 different care staff each month. This meant that the client lacked continuity of care, and the experience was perceived by clients and home care staff alike as bureaucratic. buurtzorg developed a more person-centered approach to the provision of home care, where both home health care and personal care for a group of 50 to 60 patients were organized and delivered holistically by self-managing teams of 8 to 12 nurses. The teams are composed of a mix of nurses with varying levels of education and experience. This is a really successful model. The paper describes it in more detail. buurtzorg is now the primary provider of home care in the Netherlands, and it's a model worth exploring. I know that Adria will speak more to this topic in her remarks. Next slide, please. Two other innovations worth mentioning are both related to providing dementia care in settings that feel like home. One of the best known delivery system innovations in the Netherlands is the dementia village De Hogewijk, located in the town of Wesp. De Hogewijk is a nonprofit nursing home offering highly complex skilled nursing. Only applicants who have advanced dementia are approved by the Long-Term Care Act to live in De Hogewijk. Hence, their 188 residents do not differ significantly from those in traditional nursing homes. So this is very different from the reciprocal care communities. These are people with severe dementia. De Hogewijk is made up of a rectangular block of housing. So you have housing circling this a large block, and people live on the inside. So the housing model, the architectural model, creates an intramural village. So again, that architectural and social intentionality that I was mentioning before. Residents live so not in an institutional building where staff do everything for them on a rigid schedule, but in 27 small houses of 6 or 7 clients each. This household model of care is also part of Robert, what Robert has been working on over his career in the greenhouse model. Supported by a certified nursing assistant and a personal care aide, residents in each house cook their own meals, eat together in the dining room, and do their own laundry. Now, of course, they don't do it all themselves, but they can still participate in these household tasks, which makes it feel like normal life. This contrasts obviously with traditional nursing homes. When admitted to the Hogewijk, clients answer a number of questions about their likes and dislikes and their lifestyle, and the housing for them is there's 4 different types of housing in the Hogewijk, and you are put in one that resembles the decor and the manners and the food that most resembles the way that you lived your prior life. There are many other person-centered dementia care models in the Netherlands. The model with the broadest reach is green care farms. These are small-scale operating farms that offer either adult daycare activities or 24-hour housing with care supports. There are 1,300 green care farms in the Netherlands serving 30,000 clients. About one quarter of these people, about one quarter of these green care farms serve people with dementia, while others care for people with psychiatric conditions, addiction, mental disabilities, or children with autism. For people with dementia, care farms provide a safe, home-like environment with ample opportunities for social interaction, fresh air, and purposeful activities like gardening, feeding animals, and other farm chores. Studies of adult day services at green care farms have found that they give people with dementia meaningful engagement, social interaction, exercise, and healthy diet, while also providing a critical respite to family caregivers. For family farms, offering care to people with dementia is not only a meaningful contribution to society, but also brings in additional revenue source, which helps them make ends meet and weather economic downturns. So again, killing two birds with one stone. The Dutch are very practical in this kind of regard, and it's been a very effective model. Next slide. So I'd like to talk about a few lessons for the United States that the paper discusses in more depth, but I'll touch on briefly now. Next slide, please. The first is that a key lesson from the Dutch experience is that universal long-term care financing brings ancillary benefits beyond making long-term care financially available to all. Multiple innovative providers interviewed for this project noted that both their initial investment and subsequent business model were predicated on the existence of guaranteed revenue from the Dutch long-term care system for all of their clients. Much of the risk of innovation is removed from the equation when providers can count on a steady stream of clients and revenue. The secure return on investment is highly conducive to innovation. Universal coverage in the Netherlands also means that upper middle class households are politically invested in quality care, and in many cases, person-centered care, not just for themselves, but for all. In the US, more affluent households do not need to advocate for quality person-centered care. They can simply purchase it. When everyone is in the same system as in the Netherlands, this significantly strengthens advocacy campaigns to improve care for society as a whole. Next slide. Dutch home care providers like Buurtzorg are providing holistic care, including reablement therapies to empower older adults and anchor them safely in the community. The national government is providing financial incentives to housing associations and nursing providers to build reciprocal care communities like Live-In that support person-centered aging while reducing the need for formal care. Most of the savings from these interventions will be experienced by the same public sector entities, broadly conceived, that pay for most of these initial investments: the national government and the three branches of the long-term care system, the LTCA, the HIA, and the SSA. And because the Health Insurance Act finances both home health care and other medical care, longer-term healthcare savings from these investments are captured internally as well. In the US context, the heterogeneity of payers of health and long-term care and their need for short-term return on investment makes it harder to financially justify preventative interventions. Reforms are necessary to better reward the payers making such investments for the long-term cost savings that result. Next slide. Oh, sorry, we're on the previous slide still. I'm going through these lessons in more detail. Thank you. The third lesson is that improving job quality will mitigate the care worker shortage and increase the likelihood of quality person-centered care. Dutch personal care workers earn the most among the 28 OECD countries for which data is available. They earn 95% of the economy-wide average wage for facility-based and 91% for home-based care workers. In the United States, by contrast, personal care workers earn the least among these 28 countries, 51% of the economy-wide average wage for both facility-based and home care workers. In short, the Dutch have committed to quality care jobs, and despite age-wage fiscal pressures, they're continuing to invest in quality care jobs. Similar measures will be necessary in the United States if we hope to mitigate the significant shortage of care workers as demand for care increases in the coming decades. Without significant investment in quality jobs, it is unrealistic to expect that most Americans will be able to receive person-centered care or even adequate care as they age. A fourth lesson is that innovative home care agencies can attract workers to this sector and serve as hubs of person-centered care. I won't go into detail on this. It's discussed more in the paper, and I know that Adria, who is exemplary, her organization is exemplary in this regard in the United States. She can talk more about that topic. Next slide, please. A fifth lesson is that timely access to formal home care may yield greater quality of life and even longevity than medicalized institutional care. The Netherlands invests heavily in long-term care and has less costs associated with end of life medical interventions compared to the United States. While this has not like been a conscious policy decision that's been articulated, it does seem that as a whole, the Dutch society is trying to add life to the days instead of days to the life. In by making sure that over the last 10 or 15 years of a person's life, they're living more vitally, more socially connectedly, more holistically, and with more joy and meaning in their lives, rather than spending all that money that they're currently spending on that. Could be spent on a medical intervention that extends life by 2 months, which is often what happens in the United States, where we spend a lot of money in the final month or two of a person's life. So it's interesting, philosophically, to think about, how we, as the age wave approaches, and it already is here, what do we want to prioritize with our expenditures? Do we want to prioritize a quality of life for people the last 10 or 20 years of their lives, or those medical interventions? A sixth lesson is that tort and regulatory reform embracing the dignity of risk could make person-centered care, especially nursing homes, more broadly available. Robert will talk about this, but there are a lot of, financing is the biggest barrier in getting sufficient investment in person-centered nursing home models, or kind of anti-nursing home models like the greenhouse model in the US. But there are also regulatory barriers and legal impediments as well. Because if someone falls or gets hurt, they could sue the facility. There's a lot of legal liability that doesn't exist in the Netherlands to anywhere near that extent. And so this is an issue discussed in the paper, which is worth looking at. A seventh lesson is that civic engagement and cross-sector collaboration are critical to sustainably supporting person-centered aging. Dutch civil society and providers have sprung into action to fill the gaps from a gradually retrenching public role. Resident care cooperatives are forming around the country. Adults in their 50s and 60s, supported by technical experts at the Knarrenhof Foundation, are forming resident associations to co-manage the development of new Knarrenhof communities, where residents pitch in to age meaningfully together. Housing associations like Habian, which built Live-In, work with architects, nursing providers, municipal governments, community partners, and prospective residents to develop and implement conceptual approaches to person-centered aging, like the reciprocal care concept at Live-In. Older adults are moving into these communities and committing to participating in reciprocal care. Promising civil society initiatives exist in the United States as well, but have had trouble scaling, as Robert and Adria will speak to in a moment. The multi-sector plans for aging underway in 24 states are well-suited overarching mechanisms to help bring people together from all these different sectors to address the shared challenges. An eighth lesson is that in response to fiscal and workforce challenges, the only way to avoid rationing care is to develop less costly ways of providing housing and care with care supports. I'll talk about this later in the webinar. And then finally, universal access to person-centered care is possible. So I think it's hard for us as Americans or as residents of the United States to imagine that this could be possible. I know initially it feels utopian that we could have the same kind of quality person-centered long-term care system as the Netherlands has in some respects. It already has in terms of coverage. It's moving towards it in terms of person-centeredness, but it is possible. Buurtzorg and Hogewijk are leaders, but they're part of a broader movement towards more humanistic elder care. Access to such quality person-centered care is extremely limited in the US. A lesson from the Dutch experience is that rationing access to person-centered care by income and wealth is not inevitable. If the programs like the Walk Fund in Washington State, or expanding Medicare to cover long-term care were enacted nationally to provide universal coverage, and if we made efforts to provide care more efficiently and effectively, there's no reason why we couldn't. We're actually a wealthier nation than the Netherlands. There's no reason why we couldn't achieve similar results. And I will stop there and pass it back to Allison.
Thank you so much, Ben. And that was a lot of very, very interesting and exciting information. And two, I think what you shared at the end is really helpful for us to keep in mind. Sometimes the challenges in our long-term care system can seem a little overwhelming. So saying that there is hope, that it is possible, I think is helpful for us to remember. Um, Given all of the information you just shared, I think would you mind just picking if there's one takeaway from your research that for stakeholders in the US to keep in mind, what would it be?
Thank you, Allison. Great question. So I think the biggest gap in our system to besides universal coverage is that there's a dearth of affordable housing with care supports available. And I know Robert will speak to this, but it's a massive crisis, and any family who has an older adult that's dealing with a long-term care need is keenly aware that this is a problem. I mean, ideally, people want to age at home as long as they can, but in the Dutch context, aging at home also means aging in a reciprocal care community. There's no reason why by a thoughtfully constructed with architectural and social intentionality um, senior living situation can't be a meaningful co-housing environment where people find joy, satisfaction, and meaning. So that can be aging at home as well, but it requires investment, and we don't invest sufficiently in affordable housing for seniors. So on the one hand, having more expanding programs, and we have a range of programs which are discussed in my tandem publication that are designed to make housing affordable for seniors, but it's woefully insufficient. The Dutch have invested in this since the 19th century with their social housing system, which again I discussed in the other paper. But really, it requires government investment and philanthropic investment to make capital and land available at below market terms, on favorable terms, to encourage and incentivize and subsidize the development of affordable housing for seniors. That's critical. And then, of course, the care supports, which come from a universal long-term care system, are also the counterpart to that. Both of those are necessary, but I think the biggest gap, to answer your question, is affordable housing for seniors. We need to be investing much more in that, and if we do that, that will also free up housing for younger families, in cities and so forth, who need that housing. So I think that's the most important public policy challenge.
Thank you. And that brings me right to a question that I have for Robert. Um, and I think he'll be joining me on the screen in a moment. But what are the main barriers to person-centered housing with care supports really flourishing in the US, and how can we overcome them?
Thanks, Allison. Well, I agree very much with Ben. The lack of appropriate and affordable senior housing is one of the major challenges, and certainly financing, both for construction and then operations, is also very challenging. I want to start with, however, some good news before I jump into the barriers. And I think the good news is that we've come a long way in the United States from where we started when we started building nursing homes under the Hill-Burton Act. And we've come a really very long way in the last 30 years with a lot of rebalancing toward home and community-based care. So that's a really good start to build on. We recognize that we need to change. As Ben mentioned, with the Netherlands, we recognize that we can't afford to keep doing it the same way that we're doing it. So there's some mounting pressure to marry older people's preferences to remain in the community with government and policy makers' understanding of the need to change. So I'll try to go quickly through the barriers. There are a lot of them, as you all know. And before I start, I want to say that there is a difference between the barriers between licensed supportive housing, things like assisted living and residential care, and unlicensed models of housing with services, which are typically where there is a housing provider and then a service provider is either partnered in some way or comes into the building to provide those services. Licensed models are typically provide assistance with personal care. That's a distinction with unlicensed models, and then even more so medication management. Unlicensed models are typically providing housing, supportive environments for that housing accessible, and then some non-medical personal care services like meals, transportation, housekeeping, and activities. Sometimes they provide care coordinators. Those are very helpful as well. And some examples of that in the US currently are senior co-housing, some independent senior housing, HUD 202 housing, typically paired with a supportive care coordinator. Generally, unlicensed housing is easier to develop and find investors for than licensed housing because of its complexity. So just quickly on licensed supportive housing, there's several significant barriers to increasing that supply, particularly of person-centered models of that care. Probably, I would say, in my experience, the biggest is that housing developers operate in very different worlds from aging service providers. And those two distinct skills have to come together in a licensed housing with services setting. And those are not always a natural fit. Real estate developers are afraid of licensed services. Service providers are a little bit afraid of real estate development. So a barrier is that those people need help and technical assistance to come together to develop programs at scale. Also, lower margins. Senior housing with services and long-term care typically have lower margins than other investment opportunities, and that makes it difficult to find scalable models that people are willing to invest in finance. Financing is difficult because lenders and investors recognize that there's a limited pool of eligible operators, so that if something goes wrong with their current operator, they may struggle with a building that's a little bit of a white elephant for other uses. They understand that staffing issues, workforce issues are becoming increasingly difficult and complex and expensive. And then also, equally importantly, they are often people who are lending or investing in a project are often afraid of regulatory changes over the 20 to 30 year course of their investment in the building, regulatory changes that could be adversarial to the success of the program. So you end up with a lack of willing equity investors, particularly people who are willing to purchase tax credits for licensed housing with service programs, higher interest rates, which increase costs. And then often you see the requirement by lenders that developers provide personal guarantees, and that's often alarming to developers and investors. Mentioned limited workforce, but I think that deserves being called out as its own obstacle. The paid workforce is challenging because of demographics, but also because the current jobs are not great jobs, and the dominant models of care are not that appealing for people to work in. People come to these jobs with a real desire to connect with the people they're serving, and a lot of our job structures prevent that rather than facilitate that. And I know we'll talk more about that with other panelists. There's a lack of affordable options, private pay. People who are private pay, it's difficult for an average family to afford a housing with service setting, especially in urban areas where those are now anywhere from $5,000 to $15,000 a month. Those options are in short supply, even at that price. For subsidized models, we really require investors to believe that Medicaid funding will continue to be there over the course of 20 to 30 years and sufficient. And that's an obstacle as well. The 5-year renewals of waiver, some of the lack of just cost of living adjustments, inflation adjustments in those rates. And then two final for the institutional settings. Institutional settings are often pulled back toward an institutional model of care. So as hard as we've worked to put person-centered care into models like the greenhouse nursing home reform models, the weight of the systems, the financing and regulatory systems and operating systems often will pull those models back to a much more institutional practice. So that to overcome requires a great deal of additional training, ongoing, and some costs due to the rapid staff turnover. Fear of loss of control and segregation and isolation by older people who might move into these licensed housing with services settings is also a challenge. For unlicensed supportive housing, some of the biggest challenges are that zoning rules often do not support creating those intentional communities. New integrated care options are difficult to construct due to, as Ben mentioned, scarce land, zoning obstacles, and higher construction costs. Regulations, particularly those that might trigger licensing requirements for unlicensed supportive housing, are often challenging and an obstacle. Volunteer support is very difficult to organize and maintain in those settings. people are generally not willing to commit to meeting ongoing significant needs if they're not in close relationship with those individuals. And we'll talk a little bit about why the Dutch models help with that. And then reluctance to move. We know that older people, 75% of people over 50, do not want to move from their current homes. And then quickly to overcome before we jump into, I know the next question from Allison is, a concerted effort between the federal, state, and local governments to act together with stakeholders to facilitate and help finance promising U.S. models. We do have promising U.S. models as well as some lessons to learn from the Dutch models, and to continue rebalancing toward home and community-based services. Let me turn it back to you, Allison.
Thank you so much. And I just want to say I see one or two questions coming in. Please feel free to continue putting questions in the chat or in the Q&A, and we will get to them in a moment after our panelists share a few thoughts. So I think given what you just shared and what Ben shared before about his report, what from the Dutch innovations do you think stakeholders in the US should be considering and looking towards adopting?
It's a great question, Allison. And as I mentioned, with the progress we've made in the last 30 years, much of that progress came from looking at innovations that occurred both in the US and abroad. So I think looking at the Dutch model, as Ben has done, is incredibly helpful for us. I'm going to focus in my remarks about what we might learn specifically on the community-based solutions that Ben talked about. Those are obviously the preference of most older people, and we're getting better and better about keeping people with very significant needs, both physical and cognitive and medical, in the community. So I think that's the appropriate place to focus. I will say that for people who cannot manage to stay at home for a variety of reasons, sometimes family issues, sometimes their current housing situation, that there are very good models out there of household models of nursing home. So for people with skilled nursing needs, and our current system works reasonably well to support those. We do need some help in those models with construction capital, because they do require new buildings typically, or substantial renovations. But generally, the Medicaid system works well to support that for lower income people. We have good private pay options, which need some help with affordability through probably social insurance. But that area, I think, is covered for the small percentage of people who cannot stay in their community. So my general thoughts, based on Ben's very good paper and research, is that obviously the universal social insurance that Ben outlined is a key foundation. That allows individuals to have the control to drive demand to the preferred models that they want, and to engage developers in that through their financial capacity. We need will help provide pay rates that people can afford, that will attract providers to this area. And then, of course, the current Dutch emphasis on community-based care is very important, continuing to shift the balance away from institutional care, even when those people need intensive home care through the Dutch system. We need more generous housing development and operating subsidies to get the housing in place that Ben talked about, and that's something we can learn from the Dutch approach, particularly their focus on housing as a way to save on institutional costs and redirect some of the public support for that. In the US, the way we would do that is probably increase support for tax credits focused on senior housing, as opposed to making senior housing compete in the general tax credit pool. And then finally, additional, obviously, government investment, and that can come from some of the savings to Medicare and Medicaid, much as the way that, again, the Dutch system is looking at it. The three Dutch innovations that I think we can learn from now, even without significant change to our system, and particularly without social insurance being currently in place, except for in Washington State, obviously. So I think first among the Dutch innovations, in my mind, is the facilitated cross-sector collaboration. really creating a foundation for identifying regional and local goals for supportive housing production, and then how to make that accessible by facilitating, incentivizing, and providing technical assistance to those community development efforts. We really need to solve the obstacles, which are a complete intertwining of regulatory, finance, market, consumer preference, et cetera. We really need that type of collaboration. So we need governments, developers, operators, advocates, and communities all working together, so they're not fighting each other. So what we would identify with those collaborations is how to remove some of the zoning barriers, especially to infill developments that allow people to stay in their community. How do we address land costs, either through, as Ben mentioned, donations, but also through zoning density bonuses, excess government land, et cetera. Financing, we need a lower cost financing option. Tax credits work well if they are isolated for senior housing developments. They don't compete well with less complicated developments. And then unnecessary construction costs. So there are approval delays that, let me see if I can turn off that alarm.
We don't hear it.
You don't hear? Okay, good.
Yeah.
Okay, good. So we need additional financing mechanisms, which sometimes can be subsidized and sometimes can simply be with government guarantees or other enhancements. Mentioned unnecessary construction costs, so approval delays, excessive designs and site requirements, regulatory obstacles are also a challenge. The second, I think, area that we can learn from is intensive
And I'll just
home
say,
health.
sorry, Robert, maybe 1 or 2 more minutes, and then I have some questions I want to get to for the other panelists
Okay.
as well.
Okay. Can you still hear me all right, Allison?
Yes.
Yep. Okay, great. So combining the models that Ben talked about of intensive home health, community nursing, and ancillary supports, we need that type of care coordination and unified delivery system. We have some good US models that have started to do that and could be expanded with insights from the Dutch system. PACE, Program for All Inclusive Care, is one of those. SASH, Supports for Services at Home, is doing a very good job of that in Vermont. And then, of course, hospice does that very well for people at the end of their lives. And then finally, the intentional communities and reciprocal care intergenerational communities offer a real opportunity to combine volunteering, encouraged by creating relationships between neighbors, with more formal care that can be delivered in a more cost-efficient way due to economies of scale. Let me stop there, Allison.
Thank you so much. My next question actually is for Audria. And so we just heard Robert shared a lot of really, really interesting and helpful information about as we're thinking about the housing side, the person-centered housing with care supports. Audria, I would love to ask you about what are the main barriers to person-centered home care flourishing in the US, and how can we overcome them?
Thank you, Allison. I want to first say thank you and appreciation for Ben and this report. I had the opportunity, as we said earlier, to participate in the Melting Fellowship with Ben and provide some reflections from my provider home care standpoint on this report. So I just wanted to start there. I'd also piggyback off of what Peter said in terms of jumping in on that good news that at least we're in a place now that we recognize the need to change because people want to be able to age and live with disabilities in their communities and not in institutional settings. But obviously, we still have a long way to go in order to get to a place of really realizing person-centered home care. And it's at a time where the growth of the aging population is just huge, and the workforce shortage creates, challenges and a really short window to make a seismic change that we're looking at. So I think barriers, right? I think one of the barriers to person-centered care really starts with caring about the people you're centering it on. I think in large part, we have a problem in the United States that where we aren't necessarily focused on the people who are receiving and delivering long-term care and home care. Older people are marginalized, people with disabilities are marginalized, and really the way we overcome this is by shifting the perception that people who are aging and people who have disabilities are consumers of resources as opposed to contributors, and what they bring to our society and what they actually deliver. For me, another barrier really centers around who are the people who provide this care. The workforce delivering long-term care is an invisible workforce in terms of home care provision. It's a workforce that is largely devalued and also marginalized. Overwhelmingly, those who are delivering the care are women, they're people of color, they are immigrants who go unrecognized and are inadequately compensated for the essential care services that they are providing. The way we can overcome something like this is making those meaningful investments into the jobs, despite who's providing the care, and uplifting the essential nature of person-centered care. Additionally, I see a barrier in this, in the piece around competing interests in healthcare. So we need to move to a place of collaboration, and yet, for me, I find we tend to be siloed, and those competing interests can really make integration and holistic delivery of care extremely challenging. The integration and a holistic approach to centering care on the person receiving the care, involves cross-sectional collaboration. In my experience as a home care provider, we fall behind hospitals, we fall behind nursing homes, assisted living facilities. We have to get to a place of eliminating those barriers and reducing the silos and the fragmentation in the system, and increasing an understanding of the impact and importance of long-term care in the broader healthcare system in order to really center the care on the person who is receiving it. And I will say that the single largest, or no, because these are all really significant barriers to overcome. But one that for me is woven throughout all of the other barriers really centers around funding and being able to rely consistently on funding streams. Ben talked about, the importance of needing funding streams to be consistent. For us, reimbursement rates are insufficient to provide what's needed for the workforce and for people to have access to this care. So reimbursement rates don't provide family sustaining wages for workers. It doesn't provide benefits, basic and continual training for workers, things that are really important for this workforce. And for people who are looking for or are in need of the services, it can be cost prohibitive to access the services. In addition, we talk about, the sort of the most impoverished people can get services from Medicaid, but Medicaid reimbursement rates are inadequate to actually provide these services. So the lack of adequate funding also contributes to stifling innovation. And even in situations like such as ours, where we are able to try to manage to identify sort of pilot programs, innovative programs that can help retain workers, or go around barriers to people being able to access the care, or working with clients to see how they can access the care. Even if we're able to cobble those things together without having consistent funding, there's the challenge of bringing it to scale. So, I think for our organization, we end up trying to pull different funding streams, but there's not enough consistency and stability in order, to really be on solid footing to make the seismic changes that we need to.
Thanks, Adria. I have a second question for you, which is similar to what I asked Robert, which is based on what Ben shared and what's in the report. What from these Dutch innovations do you think the US would be well advised to adopt or consider?
But yeah, I loved reading the pieces about the lessons and then listening again, to Ben earlier in the presentation and stuff. There's really so much that we can take away. And things that, there's the underpinning for already here, but it's work, right? I think lesson number one around the universal coverage with robust financing for innovation, right? That kind of robust financing, for me, I see it as really supporting high road innovative care recipient and worker centered providers, which are essentially cooperatives, but don't have to exclusively be cooperatives. Ben talked about, being able to count on consistent funding. I can tell you that we are not even close to that being the situation for us, for us and for many providers in the space. We can't count on consistent and adequate funding proactively, even in situations where we push for adequate rates, and sometimes we need to tap into additional pools of funding to be able to actually try to get to some sort of break even kind of payments. What ends up happening is that there are huge delays in funding those pools. And so what you have as a provider is either trying to figure out how do you sustain those periods of delay by financing and going into debt, or you're faced with, am I going to be able to keep my organization afloat? And that's constant. That's every budget cycle. That's it's nonstop. Was interested in the lesson around incentivizing investment in person-centered care and connection to payers, seeing a savings, making those investments. Patient-centered care does save money because you can keep people out of the higher cost settings. But from my perspective, it can be really challenging to demonstrate the cost benefit of this because many segments of the US system are so fragmented. And there tend to be far fewer studies about the impact of the home care workforce on client care outcomes. And so, research around the connection between person-centered care and cost savings from the vantage point of the value of the direct care workforce tends not to be the place where a lot of research is focused, and we need that. The lesson around improving job quality, mitigating the worker shortage, and increasing the likelihood of quality person-centered care, this speaks to me because this is us. This is the quality jobs, quality care, bedrock that we are built on. And the link between job quality and a strong, satisfied workforce is real. Workers in quality jobs deliver quality care. It is the foundation of CHCA and what we work to realize and actualize in our everyday, lives. We really work towards providing those family-sustaining wages and benefits, identifying and creating training opportunities, both at basic levels and for advancement opportunities, so that the workforce is, capable of delivering these essential services and the complex needs that care recipients may be in need of, and we need to deliver. The work and the supervision of that work has to be dignified. We look to have supportive services for our workforce, including support from peer mentors. And we always maintain a focus on job quality and look to make investments in our workforce, because that's, to us, how you get to really the delivery of person-centered care from the home care perspective. I think the value of our model, which also includes an equal ownership in the stake of the cooperative for everyone who chooses to be an owner, is higher retention, lower turnover. So that piece about continuity of care for recipients is embedded in being able to retain your workforce. We have, increased care recipient and worker satisfaction. We have a committed and empowered workforce, understands what our clients' needs are and can deliver that care and meet the needs of care recipients in their homes. And the final lesson that I just want to highlight is around innovative home care agencies can attract workers to this sector and serve as hubs of person-centered care. Yeah, this one, I guess they all spoke to me, but this one spoke to me too. Because over our 40-year history, what we have been able to do is build an organization that people recognize and workers recognize they want to be here, they want to be a part of it, because the organization invests in them, and that allows them to invest and deliver the best quality care that they can. So cooperative home care has and always has had a wait list for our training program, right? Isn't that wonderful? A workforce shortage, and we've got people waiting to go into these jobs. The challenge is that the way that the system is structured here, we actually, at this point, we can't get enough work to put caregivers into because of the way that the system is set up. So there are other providers who, however they have, created their organizations, are far larger than our cooperative. And so we could, in effect, train, and we have over the years, right? Over 40 years, we've trained tens of thousands of home care workers in New York and put them in quality jobs. But at this point in time, we have wait lists to go into our training program without enough work coming to CHCA. And that speaks to this issue of like the referral sources. I mean, Ben, this is in the, in the report. You have to be able to line up the referral sources, the financing, and have it all, work in tandem and in collaboration. So yeah, I will leave it on that note and turn it back to you, Allison.
Thank you so much, Adria. I will ask Peter 2 quick questions, and then I see that there are some questions in the chat. Continue putting your questions in there, and we will get to the Q&A portion shortly. So, Peter, it seems like the Netherlands was oriented towards a model of institutional care in the past. How did you transition to this community-based housing focus, and what was difficult about it?
Thank you, Alison. That's a great question. But first of all, I really would like to congratulate Ben with his excellent report. Very impressive what he wrote about the Dutch system. I think we are still at the beginning or in the middle of this transition. And in the Netherlands, we have a long tradition of institutional care, like Ben already told. And as well, we have a culture that professionals are used to take over care. Hence, the transition is really a culture shift, and changing cultures take a lot of time. So to make the change, a lot has to be done, and you can look at it as well at the model of Kotter, the change, this 8 steps model of Kotter, where you really first need a sense of urgency to build a guiding coalition and to form a strategic vision. Well, to be honest, in the Netherlands, we really have some urgency to change. The demand in the housing market will change severely with the aging of the population. And actually, we are a little ahead of the United States in the aging process. And you have to take in mind as well that it might take up to 7 years before a home community, a home or a home care, a care home is built. And we can't say that we didn't see it coming with the whole aging. So actually, we don't have that much time, and we really need a coalition. And many stakeholders should be convinced something has to be done. And then, first of all, I would think of the municipalities. They need to have the urge to build for older adults with and without care needs. And to get a location is one of the biggest obstacles in the Netherlands. And these locations should be preferably near, for instance, a GP and near a supermarket. And so they have to be assigned there. And you would like to have as well neighborhoods that are accessible and are inviting to walk around and to meet other people, which is, of course, very important as well for the community building. And municipalities should know what the older adults what type of housing they want to live. And this should be written in a policy paper, which should be addressed at the council, the city council. So that's municipalities. Secondly, we are building way too much for families. We really have to build more for older adults. So in housing corporations and investors should invest more in for them, and as well not only for people, but as well for older adults with severe care needs. And that means as well that this transition coincides with a shift of responsibilities from care organizations to housing, to in particular housing corporations. So the flip side of this is that care organizations as well will get a different role, and as well they will lose some responsibilities, but then their care, how they provide care, should be different, and we need different models for that. And fourthly, of course, the older adults themselves really should be in this coalition. And actually, the older peoples might be the biggest driving force within the municipality to change something. And then, of course, you need a strategic vision. So the policymakers, well, they run a lot of risk of investing in these new concepts. And a new concept for housing for older adults with severe care needs is much more on facilitating living than on facilitating care. So care organizations and builders have to work together on the new concept. And for this, you really need to invest in relations. I think as well, Robert already told that as well. That it's almost like they speak different languages. So it's really new territory for housing corporations, and even within municipalities, it looks like there are Chinese walls. So the advisors on social care don't know the people from the housing, and they have to say to each other who they are, etc. And then you have to think that stakeholders might have different interests. For example, giving care. If you want to give care, especially severe care, you need a bigger room. But then, of course, it might be more costly. And so the housing corporation thinks, well, it doesn't have to be that big, the room. So the incentives as well, they not always align, and you really need leaders and front runners that embrace the new vision, and they operate basically as well on intrinsic motivation. It's not that in particular you will have a higher return in the beginning, but you really want to change something. You really want to build something for your own. What I hear a lot about is these front runners. They want to build something for their own parents. And that's something really you need as well for the leaders that are going to make the new concepts. It's often as well that they saw something of their own parents that they didn't get the care they wanted, that they really want to change as well. And why would a housing corporation invest in a new concept with these higher costs? Building for older people is more costly than for families, with a lot of insecurity. For instance, what happens during the night? What if something goes wrong, and who's going to pay for the meeting room? Things like that. And that's as well where the government comes in. So, or the municipality, the price for land will probably be lower when the municipality sells it to housing corporations that don't get the same amount of money as they sell it to an investor. And as well, we need to stimulate something as well by the government. So to conclude on this to you, maybe I should be a little bit more optimistic about the Dutch change, because as well, 4 to 5 years ago, not many municipalities were convinced of the need to build houses with care for older adults. And I don't think there are any municipalities anymore who think that way. But it's a long and windy road, and the proof is in the pudding. So many community-based homes still have to be built, but I think we are on the way.
Thank you, Peter. I'm going to ask one brief question, and then we're going to open it up for the Q&A, so folks can continue putting questions in the chat. I do want to just say that I think a couple of things you said really resonated with me, including the silos between different sectors and how it's like they speak different languages, and also having government step in and build those incentives to innovate. This relates to my next question. We heard from Adria and from Robert about some of the challenges of scaling up of innovative models. So what has the Dutch government been doing to increase the supply of community-based housing? And just briefly in a minute or two.
Yeah. Okay, thank you. In the Netherlands, we have first of all, we have a major housing shortage. And a large portion, like 1/3, is the shortage of housing for older adults. So the projections of the government show that of the 1 million homes that have to be built before 2031, 300,000 have to be built for older adults. And the measures of the government to address this problem consist of agreements, regulations, subsidies, and providing expertise, mainly to municipalities. Consistent with what I said earlier on the need of creating a sense of urgency and forming a strategic mission, we worked out already 5 years ago an agreement with all the stakeholders, with the municipalities, house corporations, care organizations, etc. And we updated this strategy a couple of years ago. And we had a small team of advisors that went to all the municipalities that this was on the agenda of the city council. We are working on a new regulation that the central government get more options to take control and give directions to municipalities that they really have to build more for older people, or as well for other groups. This way they get just more control. But this already, it takes a couple of years before this regulation is in force. It's through the Senate. So prior to this moment, the government has asked actually each region in the Netherlands to determine how much homes have to be built, which includes the number of homes for older adults. And then you can think of normal zero-step houses, clustered homes, but as well clustered homes for suitable for people with severe care needs. And government made an agreement with the Association of Housing Corporations to build 60,000 homes, so 40,000 clustered homes and 20,000 apartments and care homes for older adults with severe care needs. And then as well, we worked out a subsidy. So housing corporations and care organizations can get a subsidy of more than $18,000 per apartment. So it might be, in total, it might be more than $1 million for one care home, which is suitable for long-term care. And moreover, we have a subsidy for the communal area in clustered homes. And then we have expert teams that can help municipalities to make plans. And another topic gaining priority at the moment is to create environments that stimulate community building and to move walking and biking. And I guess we have always been inspired by the book of Robert Putnam, Bowling Alone. So the design of the neighborhood can help use respect. What I told you as well, the accessibility of the neighborhood, the sidewalks, where facilities for older adults are in the vicinity, a road to walk with benches, toilets, a place for a coffee where you can meet, etc. And there I would like to leave it with that.
Perfect. Thank you so much. And thank you to all the panelists. I see that we've had a couple of questions in the chat. If anyone has additional questions, feel free to put them in. I think the first question I saw was from Heather. We'll try to get through these questions pretty quickly so we can answer as many as we can in the next couple minutes. So she shared, is PACE a model that the US can build upon, especially with some of the challenges around collecting savings? And I think, Robert, you had mentioned PACE briefly, so if you want to share anything else.
Sure. I do think it's a model we can build on. It is about 90% the cost of a nursing home. So it's designed for people with very intensive needs, but it's also designed to keep them in their home and in the community. So it solves a number of issues, including the fact that we don't have enough purpose-built housing. So keeping people at home is both their preference and makes sense. It is an intensively integrated program so that's good for people's health and outcomes as well. So yes, I think we can look at PACE. We can look at, are there models of PACE that would serve people with lower levels of need and be able to do that efficiently and economically in the community? We've seen a few of those. There was something called the SOURCE program in Georgia that did very intensive PACE management, including coordinating acute and long-term care, and had some successful results.
And Ben, was there anything you wanted to add there?
No,
Okay,
I want to
great.
make sure we get to the other question. So
Okay, so I see another question from Mark Drazen. I apologize if I'm mispronouncing anyone's last names, but I see that he shared really a question about many U.S. elders needing support would not be able to pay rent or fees that
right.
some Dutch families can. So can you share anything about how some of these innovations apply to lower income individuals?
Yeah, there's two dimensions to it. The first is social insurance. So the beauty of social insurance, like programs like Social Security, Medicare, or WAC cares in Washington State, or the Dutch Long-Term Care Act and Health Insurance Act, is that people pay in when they're able to pay while they're working, and then when they're in a vulnerable situation, when they can't work for whatever reason, in this case, retirement, dementia, frailty, they receive the money. So care is free at point of usage. It's virtually free. There's nominal copayments in the Netherlands. So once people are in a situation, a senior living community, they're not paying for care. So that's the first part that makes it affordable, which is a dramatic difference from the United States, where it can cost $40,000 a year for home care, or $100,000 plus for institutional. The second component is that the government and philanthropy over the last 150 years have invested in the social housing sector in the Netherlands. And again, my other publication, which will come out with the National Academy of Social Insurance in next month, or this month or next month, we'll go into that in more detail, but that keeps the rents very low. They only cost about $650 if you translate it to dollars a month, that rent in live-in, for example, which is one of these communities. And that is because the land and the capital to build these communities was subsidized first by philanthropy in the 19th century, and then by the government in the 20th century to make that possible. And the other model I mentioned, Knarhoff, has a cooperative dimension where you buy a home at a below market rate, and when you sell it back to the community at a below market rate. It keeps the affordable housing in that pool of affordable housing. So taking some of the profit out of this sector, we see high profit margins taken out from private equity and a lot of our nursing home sector now. By taking some of that profit margin out, and getting more subsidy from public and private sources. And we have a lot of philanthropy in the United States investing in all kinds of things. Why couldn't philanthropy invest in this sector, right? They certainly could. They did so in the Netherlands in the 19th century to launch the entire social housing sector. So I think that's another solution.
And then just a quick clarifying question Drew had, is the $650 per month per person, per room, or per house?
It's for an individual living in an apartment in a reciprocal care community.
Thank you. Okay, we'll see if we could get to one or two other questions in the last couple minutes. I see from Kathy, she said she loved hearing about the resident care cooperatives, which is similar to the village model in the US. What do we see as the village's role in person-centered housing and care going forward? Anyone want to take
Sure.
that one?
Yeah, I can touch on it briefly, and maybe Robert, I don't know if you want to add anything, but combating social isolation and just meeting holistic needs. The person-centered aging is about being connected to other people, engaging in the community, and having not just your medical needs met, but your human needs met, other needs for being involved in activities or going for a walk, having companionship. I think that it fills in a lot of that, anchoring people in the community, combating social isolation. I think it fills a lot of those gaps. It's not a substitute for personal care, but it does fill those other gaps. I don't know if Robert, there's anything you want to add to that.
Well, I would just agree, Ben, with you, and say that there are ways then to inject, as we've seen in some of the models in the Netherlands, to inject that personal care through professionals, through either government subsidies or economies of scale that would work very well with co-housing. Co-housing offers obviously an economy of scale by bringing people with like needs together, and can be enhanced then by either a co-located home care or perhaps home care within the community that can focus on it as a whole.
And then I see a comment here by Karen. She said that low-income housing tax credit allocation plans could promote affordable housing for older adults, but instead often disfavor housing designed to serve older adults. Does anyone have thoughts about how those tax credits could be structured?
I mean, I'll let Robert take this, but I'm just make a brief comment, which is that, the need, as Robert mentioned, this should not be an afterthought, right? We have to have a systematic approach to subsidizing senior affordable housing that makes that the goal, the primary goal. And, as Robert said, a dedicated program for that, rather than having it be a byproduct of existing programs geared at the broader population. So, Robert, I'll let you follow up.
Yeah, I guess my comment would be tax credits offer very good returns to their investors. Tax credits are driven by the allocation plan. The allocation plan can provide additional points for senior housing with services. Once those tax credits are awarded to a project, then you have to find the investor. Some investors shy away from those credits, as I mentioned, so you might want to enhance the credit amount. That could be through a separate program for tax credits specifically for this purpose. To me, this all gets down to incentives and bringing the different stakeholders to the table to collaborate through market rate incentives that either the government subsidizes or we provide some cost savings to equalize incentives across different potential investments.
And a final point on that is just that in the Netherlands, social housing, even this that was built and subsidized in the 19th century, is still in the social housing pool. Whereas in the United States, these tax credits, they expire after what, how many years, Robert? 30, 40?
Yeah, it depends, but 30 is a minimum.
Yeah. And then they stop, and then they leave the affordable housing pool. And so that is a big problem. We need a permanent source of affordable housing. There's no reason for that to, in my mind, to expire after a period of time.
Well, this actually perfect timing. This brought us to the end of our time together. Thank you all so much. And if Kristen, if you could put the link to the report one more time in the chat. If you haven't read it yet, I strongly recommend digging into all the details of what we discussed today. And thank you for joining us.
Thank you.
Thanks, everyone.